One. Yeah.
We're off. Thank you. Good evening, everybody. Welcome to members of officers, councillors and members of the public to this live streamed event today. I'm going to pass over to Peter now, the committee clerk, and he's going to ask you individually your name, etc., just to make sure that your microphone's working. Peter?
Yeah. Can I have our Deputy Chair, Natalie Nicholas, can we just see your microphone, please?
Okay. Yeah, Natalie Nicholas.
Okay, all good. I don't think I can see Angela Coleman, so we'll go on to Elizabeth Hayden, please. Yeah, that's fine, thank you. Tim Jeeves.
Hi, Tim Jeeves.
Thank you. Nick Small.
Hello, here.
Hello there. Can't see Calvin is here yet, so no. So Emily Sproul, please.
Yes, here. Thanks.
And now a little bit of trickery, Councillor Richard Kemp.
I'm definitely here.
I can see you.
Okay. Next, Councillor Sarah Jennings, please.
Yes, I'm here. Can you hear me? Yes, I'm here. Can you hear me?
Yep. Okay. Sarah Thwaites.
Yes, hello.
Hazel Brown.
Hi, I'm here.
Thank you. Councillor Paul Brandt.
Hello, yes, I'm here. Can you hear me?
Yeah. Not sure if Councillor Claire McIntyre is here. No, she is trying to get in. We just sent her another invite. And then just some of our officers, lead officers. Matt Ashton, please.
Hi. Sorry, Matt Ashton, Director of Public Health.
Thank you. And Steve Petty.
Yes, Steve Petty here. I'm subbing for Martin Farron.
Okay, and from the CCG, we have Dr. Fiona Lemons.
Hello, yes, I'm here.
Thank you. Jan Ledward.
Yep, I'm here.
And Helen Johnson.
Hi, I'm here.
Thank you.
Thanks, everyone. I'm now going to ask Vicky Robert to support the facilitation of the meeting to confirm the live stream is working. And just so that you know, if the live stream goes down, we may have to stop for a short period. Vicky?
Yeah, it's live.
It's live. Okay, good. Right, can I also request that members and officers leave your microphones off until you want to make a comment, and then obviously turn it on. Now, to make a comment or ask a question, if you put your hand up, the ones that are on the screen I will see and I'll bring you in. If you're not on the screen, then Peter will have to tell me that you want to come in. Failing both of those systems, then shout. Just shout. We need to make sure that you get heard. Okay. Obviously, when you're going to come in. Sorry.
Just before you start, can you confirm that I'm in the meeting?
Yeah, I can hear you, Frank.
Okay, thank you.
Okay, Peter, apologies for absence.
Yes, from Councillor Alison Clark and from Martin Farron.
Okay, anybody else? Anyone get any other apologies for anyone? No, okay. Declarations of interest, folks, have we got any? We don't usually have them. Okay, moving on to item 3, which is the minutes of the last meeting. Maybe I better clarify something before we go on to the meeting. When we're agreeing things, instead of going to each member and asking each member to agree or not, whatever, I'm just going to ask, is there any dissent? If there is no dissent, then we will assume that the minutes are agreed. It's something we came up with at the chairs meeting to try and make it that little bit shorter. We've got 10 items. It'll take takes a lot of time to go around 20 odd people. Okay, so that being said, the minutes of the last meeting held on the 4th of February are on pages 1 to 6 of the agenda. Now, can I move that to accurate? And if you've got any matters arising, just raise your hand or shout. Okay, if there's no dissent then I'll take it that the minutes are agreed. Thank you. Moving on to item 4, question time. No questions have been received, so that was a nice quick one. Item 5, this is the important one. It's the Cabinet Member update. So, Councillor Brandt, can you speak?
Of course. Thank you, Chair. As many of the members will know, we've been sending out, or I've been sending out, together with the CCG, a weekly briefing during the COVID pandemic, when most of the normal methods of scrutiny and update were obviously in pause mode. So, Frank, you might have your microphone still on, so if you're able to mute yourself. So thanks. Someone else may have it on as well. Anyway, I think I'll briefly talk about what's happened in the past, although most of you, if you've had the opportunity of reading those updates, will be fully appraised of the situation. Then I'll deal with the future preparation that we're engaged in. The biggest impact, clearly, initially, was on the NHS and our care homes. We've had a report from the CCC about the NHS. The support provided to our care homes locally involved predominantly 3 main issues. Infection control support through the infection control provision, which Public Health coordinates to the care home sector, which was particularly where we had outbreaks in individual care homes, and was much appreciated.
Paul, I'm sorry, I don't mean to interrupt. It's really hard to hear. Someone isn't muted and I'm struggling to hear what you're saying. I think it might be the main office in Cunard.
Yeah,
I don't know whether you can mute as well, because every time someone puts a paper, it takes the noise away, so it's really hard to hear you. I don't know if Richard can mute the office in the main
Chair, I think you might not be muted.
I'm going to mute everyone now. Okay. So Paul, Paul, you'll have to unmute yourself again. So.
Excellent. Right, I should be unmuted now. Does that actually sound a lot clearer to me? A lot clearer to everyone else as well? Excellent. All right. So the infection control service intervened where there are individual outbreaks in particular care homes and provided guidance and support reflecting the individual geography and the individual nature of any particular outbreaks that occurred in homes. It was very well received and continues to be a key plank of our COVID response in the city and in care homes. We were able to reach an arrangement with the NHS very early on that there would be no discharges from hospitals into care home settings without confidence that those individuals had tested negative for COVID. So a lot of the problems that had arisen elsewhere in the country were not a feature of what happened here in Liverpool because of the partnership working we had with our NHS partners. So a big thanks to them. But it by no means left us untouched because of the settings themselves being potentially at risk from introductions from visitors, although we invited the care homes to stop external visitors earlier than the national criteria, and also, of course, the potential transmission through staff members. And as we became more and more aware of the way in which the virus infects people, and a large number of people are infectious before they are symptomatic, and some people never become symptomatic, we wanted to make sure that we limited the degree of exposure from the introduction through staff members. I'm pleased to say that more recently, as the testing capacity has increased, there is now in place a regime whereby there is weekly, or there should be weekly testing of all staff members in individual care homes and monthly testing of every resident in a care home. And that should enable us to pick up early asymptomatic individuals. But it has to be said, I think one of the lessons that we as a nation need to learn is that where there was not sufficient capacity in the testing regime earlier on to enable us to test all the people who were potentially at risk themselves and potentially provided a risk to the people that they were visiting. Similarly, in relation to PPE, it's quite clear nationally there was a huge failing during, in my view, February, January and early March to ramp up the security of supply in relation to PPE. And that consequently meant that the system was running extremely close to capacity, and organisations that were normally functioning with weeks or longer worth of PPE supplies in reserve were running in a just-in-time process. Thankfully, again, once in reflection of the close working arrangement we have with the NHS locally, we were able to join the NHS's mutual aid scheme, which meant that personal protective equipment would be available to circulate within both the NHS and also the care home sector to ensure that the operation of the health and care system could continue to function properly during the pandemic. And that meant that effectively our care homes had access to the NHS reserves. We introduced that voluntarily locally early on, and it's a system that worked exceptionally well. The other main area of care provision in terms of domiciliary care has had because the level of intervention normally provided often meant that we saw some people saying that for the period of pandemic that they would rather not have their care package delivered, and they could either make do themselves. Or alternatively, they would make alternative arrangements with, for example, family members stepping in. So we saw less disruption in relation to the domiciliary care side of things, but we extended the provision of personal protective equipment to that sector. We are currently awaiting national guidance in terms of the periodic testing of domiciliary care workers, and we'll update the committee when we have that together. Turning to the future, we have a system now where we are working nationally with the test, track and isolate scheme. And clearly, I think as everybody will be aware, that is a key component in trying to live with COVID until we hopefully as a country get ourselves in a position where we have a workable vaccine. In the meantime, the programme is run and operated nationally, but we have been given a key role in terms of both data surveillance and also the monitoring of individual outbreaks that take place in specialist locations. So if, for example, an outbreak in a care home occurs, or say a school setting, that we would have a role. As part of that, we are setting up an outbreak control board, which gives a degree of political oversight, but also involves cooperation across borders and local authority areas to make sure that infections, which nearly always will not be respecters of local authority boundaries, can be responded to appropriately if they have cross-border or cross-authority implications. You will have noticed an awful lot of conversations about the quality of data that local authorities are getting from the national scheme, and I think it's fair to say that uniformly that local authorities and public health directors were very concerned about the quality of the data that we were getting, and it was perhaps an example of how the national government could have engaged local authorities who are already specialists in infection control outbreak through our knowledge with sexual health outbreaks and food poisoning outbreaks. If they'd asked us how to design a system, we would have ensured that it collected individual granular data, which we could then utilise with using local knowledge to identify perhaps the sources of individual outbreaks. I think it's fair to say that the data flows have got better. They are not perfect, and it may well be that in due course Matt wants to give you a bit more of a detail around that. But the lessons or the messages coming from local government generally, and Liverpool in particular, appear to be being heard at national level, albeit that it's a shame that they weren't designed in from day one. Some of you will have seen that the national government have indicated that they will devolve some powers to local authorities to implement local lockdowns if it's appropriate. I think we are still feeling our way as to precisely where areas of responsibility lay there. And as far as I understand it, central government is saying that they retain overall control about any potential local lockdowns. The likelihood, therefore, is that for the very short term, I would envisage that national government keep full control. But we undoubtedly have a real role in responding to pressures that we see building locally, and hopefully everyone will be aware of the fact that the data began to show a small uptick amongst younger people in South Liverpool, and our Director of Public Health and the Council generally chose to react quickly to that rather than waiting for it to become a big problem, and consequently sent out the public health messages early, got the mobile testing centre involved and located in the area so that it could provide assistance for and mobile testing for people who felt they might be at risk. It's also really important for young people to get the message that even though most young people are not at risk of dying from the virus, it's still an incredibly nasty illness, even if you're a young person, and you run the significant risk of infecting elderly relatives, elderly friends, and you would personally feel extremely guilty, I suspect, most young people, if they felt that they'd been the cause of infecting one of their own family members or loved ones. So getting that message out to people is a key part of our public health response. We are also at the same time trying to press home some of the other key public health messages we have, which are even more important in the middle of the pandemic. So our healthy weight program to try and encourage people to manage their weight and is key for long-term good health in the city, but particularly as now everybody will know that obesity is a comorbidity factor, which is likely to lead to much worse impact of COVID upon you as an individual. We're pressing the government and to look again at properly funding healthy weight campaigns and to give local authorities the power to use their licensing regimes, both in terms of liquor licensing, planning controls, fast food regulation, to allow us to use health as one of those criteria to regulate the way in which the city operates, because frankly, if we haven't learned through this pandemic that the clustering of fast food outlets and other similar unhealthy food institutions is something that the council needs to have a greater oversight and control over, then we never will. Similarly, in relation to smoking, we're using the heightened awareness of the risks of respiratory ill health alongside COVID to press home the smoking message, and hopefully we will continue to see improvement in the reduction in smoking in the city, working with our NHS partners where there are specific smoking cessation programs available. Similarly, we've been involved as public health in terms of the opening up of the city, the so-called city without walls. That involves us reimagining the way in which the city is going to function as an economic institution, particularly, but not exclusively, the hospitality sector. So opening up pavements for usage in terms of restaurants and other similar institutions, starting with some of the higher profile and well-used roads in the city, so Boulder Street and Lark Lane and others, and giving pavement licenses where possible, but making sure that those are provided in a way which promotes social distancing, which enables the public health messages to be continued, so not encouraging and prohibiting smoking, and making sure that we can make the city work economically and continue to thrive as a visitor destination, but to do so in a way which is safe and in a way in which people know that visiting the city centre is safe, because we know an awful lot of people, even though there has been some relaxation in the rules, are still too worried to fully utilise the extra relaxation that there is at the moment. And in reality, part of the economic regeneration of the city post-COVID is predicated on people feeling that the city is safe to visit, and that involves making sure that the public health messages are embedded solidly into the way in which we reopen the city. Looking forward, there are clearly some issues, potential longer-term issues, because we have seen residential care become a less attractive method of caring for one's loved ones, because it's seen as at the moment as a slightly higher risk institution. looking to work with our residential care providers to make sure that we mitigate any risks, or is obviously a key platform of ensuring that they continue to be a key part of providing for our impaired older people. But we're also very keen to make sure that going forward we provide more intermediate care level housing options for people. So that's extra care, that's sheltered housing, which provide less of a clustered environment, and therefore lower risk and meet people's probable wishes in the post-COVID landscape. Finally, in terms of sending out clear public health messages, it's really important that everybody knows that this is not over yet. The most recent data about the levels of antibody prevalence in the wider population suggest that it's something of in the order of about 7 to 10% of the population, depending on where you are in the UK, and we're at a slightly lower rate than London. That only 7% or so of the population have antibodies. And that means that we are looking at a situation where the vast majority of people in the city are just at risk of being infected as they were before March. It's really important that everybody realizes that we still don't have a vaccine, that the best ways of keeping yourself and your loved ones protected are to follow the public health guidelines, and that means washing your hands regularly, and that means social distancing, and that means wearing masks where the regulations require it, and also making sure that your interactions with other individuals are done in such a way as it minimizes any potential transmission. That's particularly the case in terms of tonight, where it may well be that Liverpool Football Club do exceptionally well and people feel a need to celebrate. I send out the message that I sent out before, which is please, 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 yes, feel free to celebrate, but don't put yourself at risk when doing so. Please follow the guidance. Please don't congregate in the circumstances in which you are likely to put yourself at risk, because the likelihood is that the infection mitigation and suppression that we are lucky to have achieved through all this hard work in the city since March, that can very quickly be reversed. So please don't put yourself and the wider city at risk by celebrating unsafely this evening, if you're a Liverpool fan. And very finally, on positive news, the city is leading the way in some of the international research in terms of vaccine trials. The Oxford vaccine is being trialled here in Liverpool amongst other locations, and the School of Tropical Medicine is leading the way in its international reputation in vaccine development and control. We will therefore, if that turns out to be a successful vaccine, the mood music so far is that it has done as well as can be hoped so far, then I think we as a city can rightfully say that we have played a key part in delivering to humanity a safe vaccine, which is essential to properly begin to bear down on this virus. Chair, thank you very much for that. I'm more than happy to take any questions.
Sorry. Okay, before I bring anybody in, I noticed when you were speaking then, Paul, you went on, you covered some of the areas into the next item, which is the COVID-19 reset and recovery. Mm-hmm. Did you still want to go on to that item?
I'm happy to do so.
Okay, no, rather than do that, let's just ask some questions on your update for now then. I just had a notice there were some items in there that you'd already mentioned, so I didn't know whether you combined them both. So no, it's fine. We'll take the questions on the first part and then we'll go on to that. Okay. Sarah Jennings, go on.
Thank you, Chair. Yeah, so I submitted a whole bunch of questions around care homes and PPE and testing. So the councillors' COVID questions email, and never actually got any responses. But I'm really actually very glad to hear that there is regular testing of both staff and residents in care homes. I think that was absolutely essential from the word go. So I'm glad to hear that's in place. My main concern about the relaxation of lockdown and the Without Walls project specifically is, I represent an area with one of those key streets. So Lark Lane is one of those who's benefiting in a way from increase in pavement licenses and, trying to encourage people to return to the hospitality sector. However, I have serious concerns about people's ability to judge once they've had a few beers, things like distance, behaviour, forgetting to put your mask on. Queuing is just, there's no social distancing in queues. Some of the venues seem to think that the payment licensing has nothing to do with social distancing, but it's just about them getting more covers in to make up for lost ground. And my understanding was they were allowed to spill out onto the streets to allow for social distancing within the venues. And I think there's a serious danger that people are going to take advantage of that to recoup some lost income. Now, what I'd like to know is how are we supporting those businesses in encouraging their patrons to behave sensibly? Are they putting up public notices? Do they have temperature checks on the door, for example? Do they have any kind of monitoring or enforcement of social distancing or behaviour? I know that there must be many venues across the city, but I just feel that it's an accident waiting to happen. I mean, you did mention there was already a spike in South Liverpool, and I can just see something going horribly wrong with a focus on Lark Lane. So there's quite a few little questions in there, but I think that's quite a real thing to be addressed. If we're going to focus on the hospitality industry, we have to have measures in place to be able to keep an eye on it. Thank you.
Thanks, Sarah. Yeah, there's just in terms of the regular testing of care home residents and staff, it should be said that we'd asked for that from very, very early on. But the truth is that the nation as a whole had very limited testing capacity, and understandably, the first priority for testing was those individuals being admitted to hospital whose treatment depended entirely or not as to whether they had COVID. So it was understandable why it had to be prioritised there. Although one has to say, I think that the government dropped the ball earlier on, because we should have been expanding our testing capacity so that we could test all of these particularly vulnerable settings. So the testing regime I referred to earlier on has come in early June. It's welcome, but I would have preferred to have it in, frankly, from March. In terms of the City Without Walls, this is crosses a number of different portfolio areas. The City Without Walls pavement licenses are indeed intended to ensure that business entities can continue to be viable whilst operating in a way which is both safe for their patrons and in accordance with the public health rules. There is monitoring. Well, it's easier in restaurants because you can clearly define where individuals will sit. And I know our public health team help with guidance in that respect, and will continue to try and support organisations through what undoubtedly is trading through a very difficult time. The bars are harder, bars and pubs are harder, and you are right that there is perhaps less rigorous adherence to the guidance and the rules from people who may have had a few drinks and have seen their friends for the first time in months than me as a cabinet member with a responsibility for public health would like to see in the circumstances. I think it is an ongoing dialogue we need to have with them, much of it educative. Where they are licensed premises, then there is clearly a dual role for the police, who both have responsibility for enforcing the law in terms of the coronavirus regulations, and also the police as a licensing team in the police, who, if they have concerns, either they directly or the council's licensing staff themselves will bring the matter back to licensing committee. But I think the truth is, Sarah, that we are all as a nation and us as a city finding our way, and what the best way of dealing with these particular issues are. And whilst we're sympathetic to the sometimes the difficulties that the businesses have got, we also have a responsibility to protect public health. So we are, put it this way, pavement licenses are matters granted by the council, and if you fail to operate them in accordance with the license, then potentially there are sanctions that can be imposed by the council. Those strictly don't fall within my portfolio. Those are other portfolios, but corporately we'll definitely keep an eye on it.
Thanks, Paul. Fiona, I'm not sure if you had your hand up before.
No.
No.
Thank
Okay. Okay. Nick, you're next.
Yeah, thanks. Can you hear me?
Yep.
Yeah, so it just says. Not sure if it was through there. I just want to ask about. I know we've spoken about this privately around the budgets, the public health budget savings, some of which are being implemented at the moment, and there's a consultation going on around there with the community health ambassador team, the health trainer service, family weight management, and the dental health promotion and dental epidemiology service. I was just wondering if you could give us an update of where things are at the moment and what we're seeing in terms of the impact now in terms of sort of dealing with COVID, and what we think the impact is going to be going forward, and what we're doing to minimise that impact.
Yeah, sure. The public health budget, as members of the committee will know, is one which is ring-fenced. We have seen a real terms fall in the value of that public health budget by 25% since public health was transferred over to the local authority in 2013. We had been hoping that the government might supplement the public health budget by a real terms increase, and that didn't happen. In previous years we have been using reserves in the public health budget, but those are now effectively exhausted, which meant that when we set the budget we had to do it on the assumption that the government wouldn't put any more money into public health, and that has proven to be the case, and the additional monies that the government have announced in relation to pandemic have not been directly to the ring-fenced public health budget, save for a small allocation that's to deal with the outbreak control boards, which is running forward in terms of the test, track, trace and isolate, and some program which is clearly intended to fund the additional costs of that. So the situation is also that the council, having initially been told that it would have its COVID costs met in full, that's now transpired, perhaps unsurprisingly, not to be true. The government have paid for or reimbursed some of the direct additional costs, for example, some of the costs of the additional PPE that the care home and the care sector has needed, and provided a small degree of money that we passported down to the care homes to ensure they could access infection control and also support their staff who were having to self-isolate as a result of sickness or COVID-related symptoms, and to make sure we asked the care homes to ensure that their staff were paid in full over that time. But that money has all come to an end, and also the council has sustained huge additional losses in terms of parking income, leisure centre income, all the fees and charges that we would normally have as income to the city, where the government have said that they will only reimburse us to 75% of those losses, which means that corporately we as a city are finding ourselves in a position where there is a financial black hole related to COVID opening up. We are not unique in that, but we are clearly going to have to address that position. So it's highly likely that the council will have to have a special budget later on in the year in order to try and bridge that funding gap. So very simply, the answer to your question is that the financial pressures that were present when we set the budget in March are not only still there, but unfortunately they're much bigger than they thought we were going to be in March, and we are likely to have to come back to make additional cuts. What I will say is that we won't have to make additional cuts in the public health budget because those are fully ring-fenced, but the rest of the council will be having to probably make some very hard decisions in the coming months.
Thanks, Paul. Thanks, Nick. It doesn't look as though we've got... Oh, sorry.
Sorry, can I just come back on that, Chair? Sorry to raise my hand there. What do we think the impact of that's going to be sort of going forward? Because the concern, and I totally get sort of where we are with the with the budget, and I think the way that the government have not supported councils like Liverpool on this is absolutely appalling, given the need that we've got and given what we see around the factors affecting people dying and people getting complications around this. What do we understand those emerging impact of this is going to be? Have we got an idea on that? Because obviously when we made that decision in March, we didn't, it was at the very beginning of this. It was before lockdown. It was before we understood what we know now, and it's just really to see what more do we understand about the impact on that.
Well, the service delivery of a health trainers clearly could no longer take place on a face-to-face basis during the shutdown. So the way in which the economy is and the provision of services is reopening up probably meant that the service couldn't be delivered in the same way that it had pre-COVID in any event. What we are hoping to do in due course is to provide a response which is meeting the further emerging needs of COVID, and this is somewhat covered in the next item. But in truth, I think what we would want to design and reshape is something more of a wellness service, which in particular will deal with some of the emerging needs that COVID has exposed or created, mental health in particular, but also some of the social isolation that we have come across as a result of COVID, and making sure that we provide a service that can perhaps reach more people than the health trainer service did, and reimagining the way in which we meet those wider public health needs, because in truth, I think the number of people who continue to be affected by COVID is now in the city is measured in the thousands, by which I mean the ongoing sort of wellness impact, particularly mental health, but not only. And we would want to try and reshape a service that can meet that enlarged need. Clearly, in any situation like this, within the public health budget, we have to prioritise the spending which is on infection control, and we also have to prioritise the direct clinical services such as the sexual health service and the substance abuse service that we currently have. We look to, well, if as I said, we would hope that we would be able to, in the forthcoming periods, reshape a revised service that works has a wider reach than the health trainer service.
Thanks, Paul. Hang on, Tim. I'm going to bring Natalie in first, then I've got Richard, and then Tim.
Okay. Thank you, Chair. Thank you, Paul, for that update, really thorough. You mentioned an outbreak control board. Did I hear you correctly? Yes. I don't know if you're going to touch on that in your COVID report, or you're happy to expand on that now?
It may well be that Matt can give you a little bit more detail, but very simply, there is I mentioned the small amount of additional money that we were given by government, some £4 million, to put in place a system where we can respond to individual outbreaks locally. The Outbreak Control Board is part of the governance structure for responding to that, so there's a degree of accountability, and it involves a degree of political oversight. So there are, we'll report in to a meeting chaired by Joe, and I think the other, and then the ability to have cross-authority working is key from that. So Matt can give you a little bit more detail later on as a Director of Public Health, because he's been involved in the granular detail of setting it up. It's a board that every single local authority is being required to set up.
I can update now if you'd like me to, Chair.
Sure.
Go on, Matt.
Yeah, so as Councillor Brown said, so there are some requirements that we have at a local level for how we manage complex outbreaks, and part of that is governance structures. So the way this works in Liverpool is we have a test and trace team, which is part of the public health team, they're meeting weekly, but obviously actually we're meeting every day. We're talking about this every day right now. And that feeds into a health protection board, which is a monthly board, an officer board, it's not a political board, which is a subgroup of the Health and Wellbeing Board. So the monthly Health Protection Board receives reports. It's not just council officers, it's wider partnership, receives reports on progress around test and trace and outbreak management, and directs action so any gaps and any actions that need to happen, and reports into the Health and Wellbeing Board. Health and Wellbeing Board meets on a quarterly basis, and because the Health and Wellbeing Board only meets on a quarterly basis, we also have more timely political oversight. And as Paul describes, we do that through a monthly meeting which is chaired by the Mayor and with the leaders of the other parties. And that's at a Liverpool level, but because the very nature of the pandemic is, as Paul says, it doesn't respect boundaries, we also have a Merseyside version of that, which is, I think, nominally called the Outbreak Control Board, and is a city region level board. So the leaders of all the local authorities meet and receive that information. I think we are still in the process of establishing that, so I don't believe it's actually met yet for the first time, but that's the way it will look. Thank you.
Matt. I'm going to bring Richard in now. Richard?
Thank you, Chair. First of all, we meet fortnightly as group leaders, so that we haven't had a report yet, but we could meet very quickly as part of our normal cycle of meetings if there need to be political decisions made on the work that's being done by Matt and his team. The same thing is just responding to Sarah. There's actually a meeting taking place in Allen Road at the moment of the traders looking at the City Without Walls process there. But we all as councillors do have the right to ask for licensing reviews if we are concerned about behaviour from individual licensees. So we've done that once in Allen Road, the Walton councillors have done that 3 times. So the laws haven't gone away. They've just been speeded up. We can act if we need to, and we should do if we're concerned. But I've got 2 questions for Paul, if I might. One goes back to the fact that it looks as though we're at least £50 million adrift. And I'd like to link that with the adult social care position in the city in 2 ways. The first is that Liverpool, in my view, did excellently by offering the social care providers a 12-month guarantee of the market so that they could plan effectively. What we didn't know at the time was that the government weren't going to honour their pledge of doing whatever it was, that we did whatever it takes. And we didn't foresee at that time that there would be a massive void rate in our care homes, which I would guess is going to go on for 2 or 3 years because of the reluctance of people to go into care homes because of the reputation that they've got. Can we still afford the 12-month pledge? And what do we know about the vacancy rates inside care homes? The second point relates, it is dealt with to a smaller extent than I would expect in what I think, I got told not to say this by Nadine Dorris, so I'm going to say it anyway, what I think will be a tsunami of mental health problems and indeed suicides, because we know that's what happened after a much smaller problem, effectively, which is the 2008 recession. What preparations are we making in whatever way we can and I will be asking Fiona this question as well under the CCG report, to prepare ourselves for all the staff who've seen more deaths in more distressing circumstances than even professionals have been able to do, never mind the people that couldn't go and watch their relatives die or attend their funerals. There are huge problems out there that we haven't even begun anywhere in the country. So again, this isn't an attack or anything in Liverpool. A huge problem of mental health, which is under the surface, but will come out fairly soon. So some assurances as to how we're looking at that. Thank you.
Okay. Thank you for the comments about what we've done here in Liverpool. It's probably fair to say that can you still see me? The support we gave to the care homes was actually 3 months, and then we've extended it for a further 3 months at the moment. But we're not guaranteeing it will go on further than that. But clearly, it's in our interest to try and ensure that the care home sector is as supported as it can be within the limits of the financial resources that we have. The vacancy rates vary in individual homes depending on the type of provision that they have. My understanding is, and Steve can correct me, I think there are something of the order of 80% across care homes at the moment. But in any event, you are right. I think that the sector as a whole is seen as less attractive because of the perceived higher risk in there, and that's something that we will need to respond to, and ensuring that we have all those intermediate care levels of housing offer to people for those who don't want to take up a residential care offer is going to be an important part of planning for the future, and work is underway on that. Sorry, I've forgotten your final point. What was it? About the yes, of course, mental health. No, I agree entirely, and we worked very hard originally, and we ensured that the operatives in the health and care sector would have available to them emotional and mental health support. So we ensured that all care home workers had access to the Mersey Care 24 hours a day support line, which was found very useful by members of staff who were struggling, frankly, to deal with the emotional pressures associated with providing care to people and seeing some of those individuals not succumbing to the illness. But you're absolutely right. There's a much wider mental health issue for the nation as a whole about the long-term impact of this pandemic. And I know that the work that's taking place, well, there is work already taking place between public health and our clinical commissioning group to try and map out a way of ensuring that we adequately meet that need in the future.
Thanks, Paul. Tim, sorry?
Yeah, thanks, Chair, and thanks, Paul. Thanks for the report. I just want to go back to what you were saying in the report about PPE and the problems of supply nationally, sort of in the early days of lockdown and the pandemic, and I suppose beyond the early days as well. It went on for quite a long time. I know that we did quite a lot of work locally to be supplementing those gaps in the national supply, and that there was also quite a concerted community effort to be filling in those gaps. I was just wondering, I suppose, do you have a sense of what the balance was between the sort of the locally sourced stuff and the nationally supplied stuff? And in the likelihood, I suppose, of a second spike, are we kind of in a place now, I presume that the contacts and the links that have been made locally are going to be very useful for that, but is the picture sort of nationally is there confidence in that going forward, do you think?
It's a very good question. I will ask Steve, if you don't mind, in a moment, because he was dealing on a daily, we had a daily call with each of the, or a daily roundup with the care homes during the very worst periods of the pandemic, and we were checking that they were okay. There were a number of complexities, first to do with the sourcing of PPE. An awful lot of care homes found that their regular suppliers were suddenly drying up. they were found that they were being offered alternative supplies, but frankly there were some non-compliant goods being hawked around. And if you're just an average care home, it's hard to know whether or not this stuff is the provenance of where it's come from and whether it genuinely is appropriate PPE. And the last thing you want to be doing is to be giving staff members inadequate PPE when everyone and potentially luring them into a false sense of security. And it's a very difficult and complex issue working out whether PPE is in fact compliant. And you've seen that, as a nation state, the government bought loads of stuff from Turkey and it turned out to be wrong. And that's happened with all other many other nation states as well. It may be better if I hand over to Steve to say, if you don't mind, because he had daily contact with them. He'll be able to give you a much better insight into the way in which it worked and how you envisage it continuing.
Thanks, Paul. Yeah, can everybody hear me?
Yeah.
Yeah. At the height of the pandemic, we were supplying probably around about 50% of all the PPE that was going out to care homes. We had found that the majority of the larger group care homes had already kind of successfully sourced their own PPE. Domiciliary care providers, generally being smaller providers, had found that to be quite difficult, and getting out supplies to them wasn't as well organised. But as you can imagine, if you've got big care groups, they had started to very quickly try to get economies of scale and having PPE supplied through their normal supply routes for the care home group. It then quite quickly went down to quite a minimal level, although you'll see from the next report the level of spending that we've had. The truth of the matter is that as soon as it was possible to do so, we established the council as the provider of last resort, or the provider of safe provenance PPE, as Councillor Brandt's put it. But most of that PPE was supplied through safe routes. Some of it was sourced through the NHS, as a matter of fact, and we've now got a route for some of the smaller providers like the supported living homes that are now back to sourcing some of their PPE through this additional system that the NHS has set up. We've always been the provider of PPE to informal carers and people on personalised support like direct payments. So we've always had an established supply route through the carer centre for people who obviously can't feasibly order PPE in any quantities. And we had times when actually some of the providers were able to get PPE cheaper than the council, so it was a very variable situation. So going forward, as everybody will appreciate, the use of PPE is still in operation. In fact, in terms of PPE in care homes, that has just been stepped up again. In terms of the use of fluid-resistant masks at all times, some might say that this has been a little bit of a case of shutting the stable door after the horse has bolted. But the PPE is in regular use, and it's going to go on for quite some time. And so what we have to bear in mind is that we'll continue to have a drain on the finances of the council as time goes on. I don't know how long that will be.
Thanks, Steve. Look, I'm going to take two more. Jan's going to cover the mental health side of things in more detail in her report when it comes up to the CCG stuff. I've got Dorcas and Natalie who want to ask a follow-up question. So Dorcas, do you want to come in? Dorcas?
Yes, I'm in now.
Okay.
Thank you so much for that. I've got two questions. I will reserve the other one for later. A friend of mine wrote to the bus company about people not wearing their mask. And when they got on the bus, she was told that they could do nothing about it and that the police was not ready to do anything. How can we, through our group, make this possible that people will wear their mask when they go on the bus? I know it might be compulsory for the shop, I think from Friday, but the buses, they're not using their masks. At the moment, they're not using it. So through public health, how can we ensure that the public really, like in the hospital, you go there, you are given a mask before you go in. So maybe what public health needs to do is to enforce the bus companies to make sure they have masks. I don't know. The other one, you can take it now really, is to do with COVID as well, behavior change and communications. Is there a strategy in place to support those who have been shielding and can start going out from 1st of August? Some of us are elderly and vulnerable. I've been shielding since March 13. Some will be frightened to go out because they're maybe afraid to go out. How are we going to be able to identify this group and support them? When COVID testing, when will COVID testing be available for the vulnerable patients that will be going out and the elderly? Because I will be going out from 1st of August and I'm really, really frightened, at the moment because I've not been out. So I'm just asking what strategy is in place with the public health.
Thanks, Dorcas. Yeah, two really important questions. In terms of the enforcement of the law, and it's important to realise that it's not a public health enforcement role. The police enforce the coronavirus regulations.
Yeah, I know.
So there is an ongoing discussion with the police about the right way to enforce these regulations. I think it's probably fair to say that the constant evolution and the changes in the law has meant that not everyone has kept up with things, and the police have tried to use an education and information role to achieve compliance and work on general community acceptance of the rules rather than a strictly criminalisation and court-based rules, which I think is probably the right approach. But ultimately, the enforcement role in relation to the public transport rules is a combination of either the operators and their staff, and in particular bus drivers, have the right to decline entrance to individuals and to their buses if people aren't wearing the appropriate masks, and ultimately for the police to intervene. But there's obviously a wider issue for getting the public health messages out to people. So we will continue to have that dialogue with colleagues on the Transport Authority and obviously directly with the providers as well, because they are keen to keep their staff safe as well, and it poses a risk to the bus drivers if people aren't complying with the rules. In terms of shielding, you're absolutely right that there are a large number of people who I think remain extremely worried about their own personal health and circumstances, and it's part of the reason why we've seen only limited take-up of the additional relaxation. So you haven't seen footfall in city centres and in licensed establishments up to the pre-COVID level. Directly speaking, I think the timescale in which testing at will, which I think is really what you're asking for, anyone could, is a long way away. And I say that because the number of tests which are available to be used every day is significantly, although it has increased from what it was like before COVID, is still significantly less. I think it's still Matt may be able to clear. I think it's still less than 100,000 tests done a day, and given that we've got 65 million people in the country, and individuals, particularly if they are concerned about themselves or concerned about their regular contacts, would probably want to test on a regular basis. And you heard earlier on that once a week is what's being proposed for staff members in the health and social care system. So if you were to consider that you had potentially up to 65 million people every week who might want to test, the demand could hugely outsource the potential supply. So I'm not in a position to say when they will be available for asymptomatic people on demand. I think in reality, not in the foreseeable future. Hopefully, we'll get a vaccine first. Matt may want to come in and expand that. But
if I may, Chair and Councillor Brandt, if that's okay, on both of those actually. So firstly on face coverings, although there is clearly an enforcement angle around this, I think we're actually needing to start around behaviour change and culture change and driving people to want to wear masks or face coverings rather in the first place. And clearly that's not where we have been as a society, but other parts of the world absolutely have been. So I think we've got some learning to do from elsewhere. And as Councillor Brandt said, we need to be clear and consistent on the reasons, that the benefits of wearing masks. Personally, I think there are different ways you can do this. This is my cloth face covering, which is made actually by a friend of mine. But I have also had this one made, which you might not be able to see in detail, but is actually a self-designed one based on the 1832 cholera outbreak in Liverpool. Might not be everybody's cup of tea, but that's how I've done it. And then, of course, there are commercial ones available as well. This is my Liverpool FC one. So I feel quite well prepared around face coverings. Doesn't mean we don't always forget them when we go to the shops. And as you say, from Friday, we will not be allowed to do that. So, yeah, behaviour change really around face coverings. Around testing, and very briefly, asymptomatic testing is difficult. The test is most effective when people have symptoms. So largely, testing asymptomatically doesn't carry a lot of purpose around it. Now, as Councillor Brandt described, there are some settings where we do test asymptomatically, so that would be in high-risk settings like care homes or indeed in an NHS setting. But for the population at large, you would not normally test asymptomatically because the value is not there. When you've got low levels of disease in a community, there is a risk that you will get more false positives back than you will get true positives, and therefore there is even less reason to do asymptomatic testing. However, if levels of disease in a population increase, so if you have an outbreak, that's when you might actually do both symptomatic and asymptomatic testing at the same time. The overriding factor, as Councillor Brandt said, is always going to be we are limited by the amount of capacity in the system, and therefore we have to prioritise properly. Thank you.
Thanks, Matt. Natalie, make it quick because we're vastly over time on this one.
Very quick. Matt, you spoke about the board. I'm just asking whether or not there would be representation from the different hospitals in terms of feeding in terms of the COVID, because different trusts have different strategies, and whether or not in terms of the Health Protection Board and looking at the response for disasters, if the trusts are going to be involved.
Yes. So the NHS are represented at the Health Protection Board, a number of different partners, but we also have links with the NHS beyond the Health Protection Board, so I am constantly working with them all. But fundamentally, the answer is yes.
Okay. I want to stop it there. So I take it that we can there's no dissent, and then we can note his report. The ones that I can see just nod. Thank you. Right, moving on. Item 6. This is the COVID-19 reset and recovery report. So can you just pick out a couple of highlights, stuff that we've not talked about so far, because we really do need to move on.
Yes, Chair. It's a very comprehensive report. It's available, of course, on the Council's website for individuals to read, and members of the public too. I'll just, if I may, highlight the issue about rough sleepers, which has been a big issue for us here in Liverpool, clearly, and most of the big cities in the country. We took in the rough sleepers off the streets very early on, recognising, first of all, that the provision that we then had, Library House, was inadequate because it's a dormitory style accommodation, and also taking into account the fact that this was a high vulnerable group, both in terms of infection risk themselves, because they're in an environment where they were likely to be at greater risk. Some of them had immunological impairments, and also recognizing that from a public health point of view, we wanted to make sure those people were not out in a public environment where they could cause an onward transmission risk. So we put those individuals in individual accommodation in the city centre, and they have continued to reside in those locations, and we are putting together a jigsaw of support to make sure that we, if we can, eradicate the scourge of rough sleeping in this city, and that we don't return to the pre-COVID situation in default. Most of you will have had sight of the cabinet reports, in which two reports have come forward dealing with this particular issue, but we still have an ongoing problem in terms of the funding of no recourse to public funds individuals who are, generally speaking, not eligible for housing benefit, and we have an ask for government to try and, during the pandemic, on public health grounds, ensure that those individuals are eligible for public support, and because it is a lose-lose if they end up on the streets and causing a risk to the wider public health situation. It is very ambitious to try and have a goal of trying to eradicate rough sleeping, but frankly we will probably never have an opportunity again, or hopefully we'll never have a pandemic like this again in our lifetimes, which will present us with the opportunity of having moved nearly all of those people who were formerly on the streets into accommodation. The mental, yes, I think I've covered most of the rest of it, and I think the CCG, Janice said she'll cover the mental health and wellbeing. So I'm happy to take that, unless you want me to cover any other bits of it in detail at this particular stage, Chair.
Please. Okay, thanks, Paul. Very brief indeed. I've got two people so far. I've got Nick and Sarah. So Nick, you go first, mate.
Yeah. Before I ask a question on the homelessness and things, as sort of one of the councils representing the city centre, I just want to place on record how well it's working. We've been doing lots of work with residents, with businesses on this, and there's almost everybody's telling us that the issue's got a lot better on the ground, and also sort of when we're talking to people who are out on the street, they're saying they are inside, they are getting supported. They may still be outside on the street during the day, and there's obviously a separate issue with that. But actually, people are safe and people have got that support. So it is working really, really well. And I think it's fantastic piece of work that everyone's done on that. The question I want to ask, which is on a different issue, is around flu jabs. Obviously, we're going to see a rollout in the winter of flu jabs and more people being eligible to get flu jabs. What are we doing to make sure that social care workers are getting included within that, so they're going to be entitled to get a flu jab, and that they're going to be protected, and their service users are going to be protected on that?
I'll let Matt come in with a bit more detail in a moment, but last year we said, as part of our public health role, that we would fund the cost of flu jabs for individuals who work in the care sector, and we did it for a number of reasons, but predominantly because we're very conscious that the sector is quite vulnerable to large numbers of staff. If they all go off at the same time, it could potentially pose a care risk to those individuals. There are my desire would be to repeat that again. It should be said that the take-up last year was not phenomenal. One would hope, perhaps, with the heightened awareness of the infection risk and the potential problems of manifesting COVID-like symptoms, and yes, putting yourself out of the workplace for a couple of weeks might well encourage a greater uptake this time. I don't know whether Matt wants to come in with a bit more information.
Yeah, thank you, Councillor Brandt. So we are on with the planning at the moment, Councillor Small, so we're working on the detail. It's fair to say that we don't have all the national details on this yet, so we are not entirely sure what the national programme will look like. As you will be aware, currently, roughly speaking, it's there's a target for over 65s in the general population. There's a target for under 65s in at-risk groups, and we are expecting those targets to potentially change and potentially the age range to change as well. But we'll need to wait and see what the national programme comes out with. What we will be doing is we will be encouraging uptake of the flu vaccine, as you'd expect, for what may well end up being quite a difficult winter period. So we'll be encouraging uptake for all of our staff, but for the city as a whole, and particularly for our staff flu programme. We've got the details sketched out now, which builds on last year's programme, as Councillor Brandt was talking about, and actually are increasing the target number of vaccinations we are aiming to do and to offer to our staff with a focus on frontline workers. I also am hopeful that people will be more interested in getting the flu vaccination this year because of the current context.
Thanks, Matt. Appreciate it. Sarah J.
Yeah, thanks again. Okay, it was briefly on the mental health and well-being strategy. I mean, some while ago, I think it was 2009, 2008, there was a Liverpool citywide joint strategic mental health thing created, and there was a lot of work that went into that. So I'm wondering, I mean, as I say, that was kind of a strategy for a few years at the time. Will this new version be building on that and seeing where we've come in the last decade and then looking at specifically from a COVID point of view, or is it more general than just the COVID situation?
Yeah, it's probably best if Matt answers this question directly, because it's a report that will be coming forward in due course. But I'll tell you what, I know what I think the answer is, but as Matt will be writing the report, he can tell you what the actual answer is.
Thank you. Thanks, Councillor Jennings. So yeah, no, absolutely. It's building on the previous work that's been done and updating it in the light of COVID, understanding what new needs there are in the city in general, but particularly in relation to as a result of COVID-19. So it's updating that mental health joint strategic needs assessment and developing it might be a strategy, but more likely a strategic approach to responding to those needs as a result. We will also map that then against our existing service provision in the city, not just the council service provision, but the service provision across the whole city. So VCF sector, NHS and council, and try to understand where the gaps are that might need filling, where service levels need to be increased, or indeed where service delivery models need to be amended. So that's the intention. It is a very, very important piece of work, as is outlined in the report, but we don't want to spend too long thinking about it. We actually want to get on and do something about it as well. So we're trying to move at pace on it.
Okay, thank you.
Thanks, Matt. Thanks, Sarah. Tim, last question.
Thanks, Chair. Yeah, just under the behaviour change and communications section, and going back really to what we were talking about a little while ago about masks under the last item. I've been contacted by a number of residents that, I suspect it's a significant minority of the population that are unable to wear masks because of, anxiety and mental health reasons, or because they've got difficulties breathing, and, and to wear a mask is a real obstacle to them. They're very concerned about, being able to go out and, sitting on the bus, they're scared of, being accosted by members of the public who think they're doing it because, they can't be bothered or whatever, or they're sort of concerned about, I was talking with someone today actually who, he was turned away from a shop because he didn't have any kind of evidence to say why he wasn't wearing a mask, and they said, if you haven't got a mask, you can't come in. And he's complaining, he's got an apology from the management, but that happened to him. I appreciate it's a really difficult thing because you don't want to be, of course the message that we want to go out is to wear the mask, but I was just wondering, is there any sort of strategy for these exceptions in terms of, it makes me think of disabled parking bays, and the way that, and that does seem to have shifted in the last few years, that people are more aware of hidden disabilities now. And so you see someone parking in a disabled parking bay, I think people are less likely to get shouted at by other members of the public. And I suppose, yeah, it's a similar kind of thing there, just wondering what strategies might be in place.
I mean, I agree with you. It's a really difficult issue. I think the truth is that if those individuals can bring with them some evidence to show that they've got respiratory complaints, that may assist, whether it's medication or even better, a letter from the doctors, although getting a letter from the doctors is pretty overworked already. But ultimately, I suspect we as a society are going to just have to find a way of making sure that people have a confidence to be able to demonstrate that they don't need a particular mask. It's a knotty problem. I suspect ultimately if those individuals need that confirmation, the best thing to do is to ask their GP to write a letter confirming that they fall under one of the medical exemptions from the need to wear masks. I don't know whether, Matt, there's any other.
It is a really difficult one, and Councillor Jeeves, I've had some inquiries around this already, and as you've quite rightly put it, there are exemptions, so kind of children under the age of 11, I think it is, it might be 9, but children under a certain age, and then people who have a physical or mental health condition that would prevent them being able to effectively wear a mask are also excluded. So it does bring some challenges, particularly around enforcement. What we would expect to see is the particular sectors, so transport or retail, training their staff in understanding what those exemptions are and how to treat people who claim to be exempt or who are exempt, and you know, whether they have or haven't got an idea around it. And I think this absolutely, as you've said quite rightly, goes back to the kind of the behaviour change, the communications element on it. So we are now starting to ramp up our communications around the need for people to wear face coverings and why it's a good thing, but it absolutely includes within that message the fact that there are exemptions.
Okay. Thanks, Matt. I've got Fiona next, who's going to give us the answer.
Thank you, Chair. I don't know that I'm necessarily going to give you the answer, but I'm going to give you some information. We absolutely cannot be asking the public to contact their GPs or their doctors for a letter to be exempt from wearing a face mask. So primary care over the last 2 to 3 weeks has become exceptionally busy again. We are struggling to meet demand of all the stuff that didn't come forward throughout March, April and May. And the British Medical Association has been very clear that GPs are not to issue letters. In a lot of cases, the letter is saying nothing other than this patient tells me that they suffer from anxiety when they wear a mask, and really that's not a good use of our GP's time. So please ask your GP to provide a letter. There is a national website that you can go on where you can self-declare and print yourself a certificate. Thank you.
That's what Natalie, is that what you were going to say? Go on, let's come in.
I can send the link to members, because there's a link you can print off so people can walk with it if they can't wear masks. Yeah.
Excellent, thanks very much. From my own point of view, Liverpool adopted the social model of disability, and you cannot ask people what they've got and what they haven't got. We operate the social model, so self-declaration is all you need. So if someone's not wearing a mask, it's their choice. Whether they don't have to declare they've got a disability or anything, it's their choice. Okay, can I take it that if there's no dissent, can we agree that report? I'll take it that's a yes. Thank you. Moving on, and we'll have to move on pretty quickly, is item 7, which is Liverpool CCG Health Issues Report. This is always very brief anyway, because everything's in front of you. Jan, Karen, Fiona is always very good. So off you go, Jan.
I get the message. I'm going to just draw out 4 issues, and some of them, the lacks a bit of detail in the report, which I'll take back into the office. So one, around mental health. Absolutely, you'll see that on the report it's a key priority for us. We've learnt a lot from what patients and staff have told us about the experiences they've had from working under extreme pressure. in very, very difficult circumstances across all sectors in the NHS, and within that I include the care sector as well. So very rapidly we stood up services directly into mental health provision for staff to be able to access the support they need in dealing with bereavement and families and circumstances that they were operating in, which was unprecedented. So those are available. We've also seen a significant increase in people coming forward, particularly for help from primary care, for mental health provision, nearly a third up on what you would normally see this time of year. So it is unparalleled, and services are struggling to cope. So just bear that in mind. It's not easy to stand up additional services because they're at fixed capacity already. But certainly we are working with Merseycare to look at how we could use some alternative services to help support that, including telemedicine, which has been a real success story, and we've managed to support significant numbers of patients at home with self-monitoring so that we can identify people whose conditions are deteriorating and make sure they get services in there rapidly so that they don't need to be admitted to hospital. And we've managed to roll that out successfully during the COVID period. So we're working with Merseycare to see if this would be a way of identifying those that could use those types of services for mental health conditions as well, which would be a first. As I say, we're working closely with Merseycare and other providers of mental health services to look at what we can do further. So it's one to keep an eye on, definitely. I think the other one is around public confidence in NHS services. Part of the challenge we've got currently with services is with the infection control prevention procedures that we've got in place. Our capacity to treat people that are waiting is severely limited. So you will have heard that nationally we're trying to recover, but capacity in our diagnostic facilities and our inpatient facilities are severely impacted by the infection control requirements that we've currently got, and we want to treat people safely and appropriately as you would expect us to. So bear with us, there is a significant wait for services, but we're trying to clear the backlogs that we've got. Unfortunately, when people don't come forward early, then they tend to be much more poorly when they do get admitted to hospital, and are taking us a bit longer to treat them and get them home again. So we will keep you updated on what the position is, but it's for understandable reasons, and we'll continue to try and increase capacity across all sectors where we can. But if people are being offered an appointment for surgery, please take it up. We are managing the infection control. People are not being infected with COVID in hospitals. We are now down to only 8 patients that are COVID positive at Luft, which is Liverpool University Hospitals Trust. We've seen a significant reduction in the number of people infected with COVID in the NHS. So it is safe when you're offered treatment to access it. So we'd encourage people to do that. The other thing to note is the amount of system working that has been a real positive across Liverpool, across all sectors, between all agencies. And I can't thank both voluntary community, volunteers that came forward, the local authority and others that have worked tirelessly over weeks to try and make sure that we don't leave anybody behind or anybody isolated or anybody that is struggling. It's been unprecedented, and I think from an NHS perspective, we just need to celebrate that for Liverpool.
Fantastic. Thanks a lot, Jan. I must agree with you on the last point. Our community has been absolutely fantastic, the way they've pulled together, even down to little 2-3 streets, all supporting their own neighbours. Just before we move on to questions, I just wanted to reiterate what Nick said about the homelessness strategy that we've come up with. It's absolutely fantastic, and a lot of credit's got to go to Paul and to the team for pulling that together. When he did the presentation to us, it was unbelievable. It just seemed to lift everyone off. Brilliant stuff, Paul. Well done. Okay, I've got questions. First one is from Richard and then Emily.
Thank you, Chair. Three quick questions, not necessarily quick answers. First one, I'd just like to follow up your last comments on the strength of local working in Liverpool, which I entirely support. But at the same time that councils have been given more powers, because it was quite clear that centrally the government couldn't sit in Westminster and Whitehall and pull levers and things to happen. Nevertheless, the Prime Minister is talking about a reform of the NHS to keep what you describe here, a command and control of the CCG's normal functions. So are your days numbered? What's NHS CCG nationally doing about it? Or what do you think we should be doing about it? The second thing is this allows me to return to a hobby horse of mine, because it's quite clear that the coronavirus is killing people or seriously damaging people who haven't had the benefit of a strong public health regime, because the NHS has put its money continually into the acute institutions. So what are we doing to move budgets into public health? And I think I've mentioned in every committee that I've been at, I still haven't been contacted by my local primary care network to say what they want to do with me, with the council, with all our partners on a neighbourhood basis in the city. And I have tried to get in touch with them. And that leads, of course, to the situation, what are you now recommending about social prescribing? And lastly, there are some positive things that have come out of the coronavirus in health terms. I appreciate more people are coming into your GP surgeries, but I also suspect that a lot of people who would traditionally come into them, the worried well, I think you professionally described that, felt that they weren't dying at all, and a couple of paracetamol would actually cure their illness. And similarly, a lot of people went to A&E unnecessarily who haven't done. So what are we going to do together to make sure that effective triage takes place in community pharmacies, in the community, in a variety of ways to stop the pressures building up on the GPs who otherwise will be swamped again in the way they were up to 5 months ago?
Thank you, Richard. There's a lot to respond to there. You're right, the answers aren't going to be short. As for government and what's being proposed, there is a proposal for legislative change. I'd be surprised if that was this year, given the agenda that the government are likely to have and the concerns that they've got ministerially about winter. But I think you are right. We do see that they are wanting to change either the number of CCGs or whether they will have a role in the future at all. What you can do about it, I really don't know, quite frankly. And if I do find out, I'll let you know. Because obviously I think we work well in the local situation. So, you know, I understand your concern there. Around the primary care network, I'm not sure which network you fit within, but I will be happy to provide any introductions that are necessary. And I think from a social prescribing and a prevention side of things, you know, the CCG has done a lot to encourage, support and prioritise prevention. But as you say, I have an awful lot of people queuing to be seen in the hospital sector. And it has felt very much like that is all that has been the NHS has been interested in most recently. In response to the numbers of patients going through A&E and GP surgeries, whilst I might agree with some of the sentiments, we've also had a significant number of patients who did require hospital services that didn't come forward. So whilst we've also got some that may not have accessed treatment appropriately, we've also had some that were desperately in need of it and didn't come forward. So any answers to how we address that, obviously we would want to listen. I think there will be changes, particularly coming for winter. around access to our accident and emergency department. I'm aware that there are proposals now to make sure that you have an appointment before you attend, as opposed to just allowing for people to walk in, because it's really difficult to police a waiting room when people just turn up and maintain social distancing. So there will be, I think, more formal triage processes put in place to enable us to try and help manage over the winter period. But I would keep you informed of that as and when those changes come into being.
I just want to say that it isn't just a question of introducing me to my PCN. Most of the councillors I've spoken to throughout Liverpool haven't heard from their PCN either. This needs a corporate approach from the PCNs to the council and councillors.
Yeah, we can arrange that.
So can I come in there?
Council for defence.
Well, no, because I wasn't sure whether you were asking as a councillor or as a patient / resident for contact from the PCN. Am I right in assuming you mean as a councillor?
Yes.
Yeah. Okay. And I think that's fair. Fair comment. I suppose in the defence of the PCNs is that they are still a relatively new concept. We're a year in, and COVID has stolen some of that time from them. They were just getting to the point of being more effective and getting up and running. The GPs who are taking on the leadership positions in the PCNs, for most of them, these are new GPs who are new to these leadership positions. There's been a huge amount of work for them to do to get their PCNs to a point where they are a functioning entity. And the queue of people asking to engage with them is fantastically long. It's fantastic because there are so many people who are keen to engage with them, but it has meant that the PCNs have struggled to get round everybody. I think it's that rather than not seeing the value of engaging with the local councillors, but we will certainly pass that on to them to encourage them to do so. That's all.
Do you want me to ask my question now? Are we waiting for Richard?
That seems like a good idea.
Okay. So part of my question has been asked by Richard already. In terms of the NHS organisation, but I also wanted to pick up on one of the points you said towards the end there about other services coming back in, and so particularly things like cancer care and those kind of longer term treatments that we know lots of people, and I've seen all sorts of horrible stories on BBC about people succumbing to the cancer because they haven't been able to get the treatment. Or we are kind of aware of all of those people and we're getting them in as fast as we can, based on everything that's happening.
Yeah, and there's a lot of work going on to ensure that people are treated in order of urgency as well, across both Liverpool, but Cheshire and Merseyside as well, and we're maximising every available capacity we've got for access to treatment across the system. So cancer services are increasing and improving faster than some other services, I may say, because there is obviously a clear prioritisation for those services, but also we're seeing access to cardiac care as well, which is just as time limited in terms of appropriateness of access, and stroke services coming back on stream. So where we need really quick access to urgent treatment, we are seeing an increase and improvement in access rates across the board. It's not to say there aren't still a lot of people with an urgent need that need to be seen.
And just to follow up as well, in terms of, so currently if it's kind of scheduled treatment, there's a 2-week isolation time before you might come in for something. Presumably there's an element of flexibility if they need to get you in sooner, or if You know, I'm just thinking if people
If it's
can't
more
isolate
urgent, absolutely, then you would be tested, but you can't isolate if that is so urgent that you need treatment immediately. I do understand that. I think that will be revised because it is incredibly difficult to do, and it's even more difficult to do if you're a child because you obviously live in a household. So I think that guidance will be relaxed somewhat. We don't know what to yet, but it is a difficult one.
Okay, thank you.
Okay, thanks a lot, guys. If there's no dissent, can we agree the report? Dorcas has sent through a load of questions, but we're going to respond to it separately, and then we'll include Dorcas's questions and the responses in the answers, because we really do need to move on. They're not hard questions. All right. But they will be minuted, so don't worry. So I'm going to take it that they put that report agreed. Item 8 is the Health Watch annual report. Now, I like this. I always look forward to all this, and this is no different. It's brilliant. So if you get a chance, do read it. It's very good. So without further ado, Sarah, do you want to give us an overview?
Yeah, has my sound come on? Okay.
Yeah, you can hear.
I'm going to try and keep this brief because obviously we've had a lot of conversation so far. Annual reports always feel a bit behind the times. By the time they're written, it feels like we're living in another universe, and that's especially the case this year. So looking back at the report, it's all about the engagement we could do back when we could go out and talk to community groups about their experiences, where we could go and visit care homes, where we could even run a play about people's experiences of hospital care. That just feels like another lifetime ago. And remembering back in early January, we spent a day in different A&E departments at both Aintree and the Royal. And I have clear memories of standing talking to one particular woman in a bay in Majors. And I didn't realise at the time that so soon after that would be the COVID corridor, and that I would find myself in exactly the same bay with a diagnosis of presumed COVID positive. So times change very quickly, and I've got a lot of nostalgia therefore for last year. So looking back at last year's report, I miss those days. I'm going to cover a little bit of the highlights from last year, but I'm mainly going to focus on what we're going to do this year and how things have changed because, as I say, it feels like a blast from the past. So it talks about some of our engagement we did, hearing about 7,000 people's experiences of health and social care services. And that was done through surveys, focus groups, in-depth one-to-one interviews with people who'd had kidney transplants, for example, visits to places like homeless hostels to gather their experiences of the services, community events, and it covered things like social care, GP services, hospital care. We visited all the hospital trusts to talk to patients, mental health services, special educational needs and disability, absolute massive different subjects that we covered. And then those reports, obviously, it was reports on the website, but also back into decision-making forums, of which we sit on so many different boards and get involved in a whole range of the decision-making. And a lot of that is also supported by our community engagement board, and which the Carer Centre are very valuable partners on, and so many of the other sort of partners around the city, because they give us insights into what people are telling them on a regular basis. We've also got the inquiry service, which helps people to understand what is, even in best of times, a maze of health and care services. And we provide the NHS Complaints Advocacy Service. We'd obviously hope to try and help people to resolve their concerns before they become a complaint, but when they do and if they need an advocacy support, we're there for that. There's a lot more in the report, but by the end of the year, obviously, we're into COVID territory. And like everybody else, we moved to working from home. A lot of our information work was then changed. It became about how to make sure people had access to the right information about COVID. So we maintain the Live Well directory, which over the course of the year gets over 250,000 visits and over 700,000 page views. And it's often used for people within the system as well as the general public. So we made sure that had new sections in on COVID. And the information pages we added there became really useful resources for the social prescribing link workers who were indeed phoning vulnerable patients on behalf of GP practices. So it had information on different community groups that sprung up to provide food, services you could receive within the home, access to early mental health support. All of that information was gathered so that it was easy for them to use. We also set up a survey to gather people's experiences of COVID, talking both of COVID itself and people who've had experience of COVID, but also people's experiences of their own normal physical health care, their mental health, social care, a whole range of different things. And I report on that, or the first period of that is just out on our website today, and I can pass a link to go out in the papers. Not surprisingly, people's experiences vary dramatically. It's one thing to be dealing with COVID if you've got a nice spacious home and a garden and a job that allows you to work from home and you've got internet access. If you haven't got access to the internet, it's a very isolating time. And if you were trying to, for example, home educate children, including children with special needs, in a cramped flat with no garden and no car, your experience is going to be a million miles off. And again, for key workers, the pressures of going out into what felt like a very vulnerable situation as well. As a result of what people have been telling us, we've revisited our priorities for this year, and it ties in a lot to the work we've heard about so far. We're obviously going to be carrying on engaging with people around COVID because this is not going anywhere fast. We've got a project with care homes that we've been working with council officers and others to plan out. That's going to include interviewing care home staff and in-reach staff about their experiences in a cross-sample of care homes, so that we see what their experience was actually like, and any learning from that. And I'm also talking to family members, because what we've heard so far from family members is it's not just the fear of your relative becoming infected in a care home, it's the fear that you won't be able to speak to them, you won't be able to contact them. So it's the one thing that makes it slightly more bearable when a family member needs to move into a care home normally is the thought that you can go and visit regularly, that you have that confidence that you can see that the person is being well cared for. It's very difficult to then trust people that you don't know to look after your relative when you can't go in and have that regular assurance. So it's trying to find ways that we can make that work more smoothly if we do end up with a second wave, because obviously you do want to make sure that people aren't going in and bringing the virus into their homes. But it's very, very difficult to not have that contact. We've found same as everybody else, we're expecting an absolute inundation of mental health cases. 2/3 of respondents to our survey have said that the pandemic had a negative impact on their mental health. Some of those were people who had previous mental health issues and it just exacerbated them no end. But a lot of it were people who previously didn't consider themselves to have a mental health issue and are finding themselves dealing with stress, anxiety, depression. And so that's going to be kind of a top priority for us. And our other priority moving forward is around equalities, because we know that the impacts of COVID didn't land equally. And in terms of infection rates, death rates, people's experience of shielding, there's so many different variables in people's experiences. And from the survey, we've found that people who have long-term health conditions or people who are disabled have a very different experience, more negative effects on their mental health, which is not surprising. If you're isolating and shielding or there's other barriers to you, it's going to feel particularly difficult. Carers in particular, really badly hit. And if you imagine if you were caring for somebody who doesn't understand what the pandemic is and what social distancing is, the challenges of trying to maintain a routine and trying to reassure people in that situation is just incredibly difficult. So some people have been under huge amounts of pressure, which I think we all recognise, but sometimes it's reading people's, it in their own words is really quite hard hitting. So I think that's kind of, one of the bits that we're also getting more feedback on is around different models of service delivery. So I think people initially were very, very supportive. People didn't want to go anywhere near services. People were really glad that they could be treated at home. But what we're finding is that those don't work as well for every situation and for every type of person and patient. And people with hearing issues or people with autism in particular fed back that they find remote consultations particularly difficult. So it's trying to find ways that we build on the best of the changes for those people in situations it works with, but trying to also take account of those situations where it doesn't work well for people's needs. An example was given to us, so we have a regular student health and wellbeing group, and one of the therapists was telling me about how difficult it was when she was trying to do phone support with somebody who was in the room next to other family members where that's a traumatic circumstances that they needed support and counselling for, and of patients who'd left the house and gone out and did their telephone support interview walking around the streets nearby because they were trying to find some privacy from family members. So there's a lot of situations in which remote access is going to be very challenging for services and for patients. But on the other hand, people are really, really pleased that services have been able to continue as well as they have done in the circumstances, while acknowledging the impacts of where services have stopped or they've been delayed. And people have talked to us about the stress that they feel when their cancer treatment or other treatment has been delayed, And I think clear communication with people. Sometimes the things that people might have been considered to be a priority for and might have been expecting relatively quick treatment, and they will no longer necessarily be a priority. If need for treatment and surgery is based on need, you may have been sitting on a waiting list, but if your need is not clinically that severe, you may well find that you're waiting an awful long time, and how that's communicated to patients is going to be really important. Trying to think of something else. Oh, one positive to end on is Wellbeing Liverpool. So just before the pandemic, we were about to launch this site. So we love the LiveWell site, but it's really overwhelming to use at times. And we've been working with social prescribing link workers, because there's been a lot of new enthusiasm in recent years for building on community assets, all the great activities that go on in community centres and organisations in normal times around the city, and helping people to find those to benefit their own well-being. And so we'd worked with link workers and others to set up this site that was going to have really sort of motivating messages and images of local people enjoying those activities. And they were all set to launch with 3 community launches at the beginning of April. Obviously that didn't happen. But what we're now hoping to do is launch that at the beginning of September. And it's got a new facility on it where people can search just for activities they can do from within their own home. So people who are shielding or continue to not feel safe to go out and about to community organisations can feel a little bit less isolated, because they can take part in the community choir or whatever else it might be from the comfort of their own home. It's not ideal, but it feels that it's part of people returning to normal. And if you've not been out and about, losing those social contacts is really challenging, and it's to try and give the link workers a tool to help people in that situation, but also members of the public to access it and find their own. The motivation to get out and about and to start communicating with other people again and building back up some sort of life in a safer way as possible. And then the final bit is just an acknowledgement this is going to be a really tough year for us as well as for services. All the ways that we would normally rely on being able to hear people's voices are much harder. I'd normally be able to go and stand at the bedside or in a waiting room of a hospital and have floods of people coming to tell me about their experiences. None of that is possible. We have to find different ways of doing it, and ways to allow the people who aren't necessarily on the internet or forthcoming about coming to tell us. We've got to find different ways. So we'd definitely welcome anyone's support in ways that we can get kind of the message out there that we do want to hear, and that what might be one person's individual experience to them isn't necessarily. If we can gather that and give it voice in all the decision-making forums, it can have more of an impact than one person just thinking, well, this is just my experience of care and this is just my concerns.
Thanks, Sarah. Can I just ask, for the next meeting, can you give us a brief update on the COVID work that you're doing at the minute? If you will, please.
Yeah.
You won't get a lot of time to present it, but just it'd be good, really good if you could put something in writing for us.
Will do.
Thanks a lot, Sarah. Members, questions for Sarah? Okay, great stuff. See how good your report is? Okay, I take it then that there's no dissent and the report's agreed. Thanks a lot, Sarah. It really is a good one. I would recommend that everyone get on the website and have a look at it. It's brilliant. Okay, moving on, item 9 is the scrutiny panel update, and members will be aware that last year we appointed a scrutiny panel on insourcing adult social care. This was chaired by Councillor Mumby and other members being Councillor Coleman, Clark, Hayden, Jennings and Small. I'm pleased to advise that the panel has produced its final report. This is now in the council sausage machine, as Chris always says, but it's been going through the process, and it's on the agenda. It's an agenda item 11 on the work programme. So I'm recommending that we take that as one of the main items at the next meeting. We certainly couldn't talk about it tonight, not now. So it's more important than ever that we actually go through that in a more positive way at the next meeting. That's the substantive motion. Is that okay with everyone? Any questions, anyone? Is that all right, Richard? Okay. That's what we'll do then. So thank you for that. Okay, item 10 is we've got notice of a motion, sick pay for care workers. Alan,
is that one of these? He wasn't sure. I can't say obviously, but I said I'd speak just anyway.
Okay, do you want to? Yeah,
sure.
Rich, please.
This is particularly topical now because since Alan has moved this, we've moved into a whole debate about what is fair pay and fair treatment for everyone in the public sector. And some people got involved with inflation increase. Was it the beginning of this week or the end of last week? Anyway, very recently. Others didn't. And I think rather than deal with the detail of this motion, I just want to talk to the generality of it, because I think that we would all agree that our social care staff, who already get a remuneration approximately 20% less than their equivalent in the NHS, have kept the fabric of our society going, and they pay the price for it in some cases with their lives. But we are still expecting people to deal with some of the most difficult health and social care cases imaginable outside the clinical section on a minimum wage, not properly supported in a variety of ways, and without respect that should be given to them, because they all get classed as people who are not professionals. They're unskilled according to some people's definition. Well, they're not unskilled according to my definition. They are people who give their lives to caring for our elderly and our young people with particular health problems. So I'm interested to hear what the response is, but even if you can't accept the detail of this, and that's of course the Cabinet member from the way it's phrased, I do hope we can go forward with the principles behind this motion and say that we need to ensure that so far as we can as a council that we protect all the rights and working conditions and improve them of our frontline social care staff.
Okay, thanks, Richard. Paul, your response to that?
Yes, thanks, Chair. I think the analysis set out in the motion is something that nobody would criticise. It's absolutely disgraceful about the way in which social care sector as a whole is under-resourced and is under-provided for. I think also the interaction between sick pay, particularly for those individuals who are off work as a result of the coronavirus requirement to be self-isolating or otherwise, such that the system should be structured so that we're not financially do the right thing to protect people for whom you are providing. Can everyone still hear me or not? No.
Yeah, sorry, mate, still, I can hear you.
I think unfortunately that's okay. All right, Richard. The only point I would say in relation to the resolution is that, in truth, matters of sick pay interact between national legislation for statutory and also non-statutory sick pay levels of it and the affordability of it. There is no doubt that if we, in relation to bullet point 1, I think it possibly presses on us to do something that we don't have the power to do because there are certain restrictions on contracting. We can't compel providers to pay to have certain terms and conditions with their own staff, and even if we were, there is an on-cost to that, and no doubt they would come to us looking for it. So there is an affordability issue for us as a local authority, and I wouldn't want to unduly raise well, put it this way, I'll make it a general position never to promise something unless I can deliver it. And the truth is, I'm not sure we have either the powers or the resources to deliver the first bullet point as a local authority until we are properly funded by government. And similarly, I think the bullet point 2 might raise expectations in the circumstances where we couldn't deliver them locally. What I would suggest would be a way forward would be wholeheartedly to endorse all the substance of the resolution and to maybe replace bullet points 1 and 2 with a recitation for the cabinet and for MP and for local MPs to do all they can to ensure that those in the care sector are properly remunerated, including no reduction in income if they are on sick leave, and to make sure that the central government properly funds local government for the provision of social care as a matter of urgency. Because both of those two things seem to me to deliver the substance of what the motion is trying to achieve in a way where we are rightly campaigning to the organ that in reality has the capacity to deliver this, which is central government rather than us directly.
If you'd like to say that again, sorry. You're muted, so just try it. That's
all right. That would be very acceptable, Chair, and we'd be pleased if we can carry on unitedly on the basis that Paul has just indicated.
Yeah, I was just going to suggest that rather than us move forward with the motion that's on the table, is that we look at it in another way through you, Paul, if that's okay, and then you can come back with something with proposals, if not proposal, at least what we can and can't do. If at the next meeting or the one after.
Sure, Chair. And I'll put in writing the substance of what I just suggested a moment ago, that Councillor Kemp was kind enough to agree, and that can go in the minutes as the agreed item, if the rest of the committee agrees, that is.
Yeah. Is everyone okay with that? Lovely. Did you want a question, Sarah, or are you happy? Okay. Happy with that, Richard?
Yes, fine.
Okay, thanks a lot, guys. That was nicely done. Okay, the item 11 is the work programme, and as you know, we've got a really truncated schedule this year, so we've only got 2 meetings left after today. That's truncated to death, really. So we've already got a couple of substantive items. The final one being the report of the first one being the scrutiny, the report from the scrutiny panel. And we'll also have a pre-decision scrutiny on the re-procurement of the sexual health services. Any further suggestions, anything else that you think we should be looking at? Bearing in mind we've only got 2 meetings. If you forward it on to Peter now, the good thing is in that you've got a couple of months, so you haven't just got 6 weeks. So you've got a couple of months to come up with something that if you're interested in it, by all means, forward it on to Peter, and we'll take a look at it when Peter and I meet and see whether it's possible. Rich, go on.
I just want to say, bear in mind that 90% of this meeting has really been looking at coronavirus, and that's going to dominate us for the next couple of years. I think we want to keep the big picture stuff on the agenda. Because there'll be lots of things we might want to look at in detail coming out of that over the year.
Yeah, I agree wholeheartedly, Rich, which is why I asked Sarah to come back with an update on what they're doing around COVID, and I know Paul's going to be sending out stuff fortnightly to us. Nick, sorry, Nick, I've only just spotted your hand. Go on.
It's okay. It was just to echo that, really. I think it's been really useful having the COVID reset and recovery on this agenda, and I think having something similar on every agenda as a standing item of really useful, because I think lots is going to change, and we should be able to. We need to feed into that to shape that as well. I'm quite concerned about some of the long-term impacts on this around mental health and things that we just don't understand yet. So having that as a standing item would be really helpful.
Well, as I said, I think we've got Sarah coming back from a health watch point of view. We've got Paul doing his briefings. Jan's going to come back with the health watch stuff. And again, if you wouldn't mind concentrating on the mental health side of it when you're doing your reports, and maybe that'll cover next questions. As I say, anybody else got anything at all, then please contact Peter. Go on, Sarah.
Right, yeah, it sort of goes, if I may, it sort of goes back to the CCG report and how we're playing catch up with the scheduled procedures, things like that. I was thinking, what is this doing to our screening systems? We had a panel on breast cancer screening, and I'm just wondering how that's going to.
Okay.
and going forward whether there's going to have to be some kind of revision of targets.
Okay, we had a scrutiny panel on the breast cancer screening, didn't we? Which is...
We did, and that's why...
Well, that can be, you can just continue.
Fine.
That can just continue now. So, Natalie, go on. You chaired it anyways. Go on.
Thank you, Chair. Yes, Sarah, we had a bit of a stop because at the time we were preparing for election, and then Sandra was leaving, so Matt was taking over. Then COVID came up, but Peter will be contacting members who are on the panel for us to, now that Matt is in place, so we can have a meeting and push forward with that group, and Chair will also be there because it's something we need to progress, but
yeah, absolutely.
Due to systems beyond our control, we could not carry on. Peter will be contacting you shortly.
Okay.
If I may
go on,
say,
Sarah.
It was in no way a criticism of the panel. It was just resetting of targets, I suppose, given the restrictions in time and capacity, and looking forward to how that's going to change, how we assess that and how we're performing locally. So not just the that's a very good example, but across the board, really.
Yeah, no, that's fine. We were only speaking about it this morning, in all honesty, so I'm sure Matt will help you with that and push that forward. So yeah, just start it up again. It's already been okay through the committee, so just keep it going until you get to the end of it. Okay. Look, guys, thanks so much. This is an experiment in foolishness, I think, but it seems to have worked. For the most part, we've got through it. So thank you very much for your patience. I know it's been a long meeting. The COVID thing's taken us all by surprise, I think, and well, not by surprise. Paul's on top of everything. Yeah, but it'd be nice if you could, but you can't. So look, thanks a lot. I appreciate your time and your efforts in this, and thank you for your question. And I'll see you in on the 7th of October.
Thank you, Chair. Just before
Thanks a lot, guys.
Can I put on on record my thanks for the staff team. They've been unbelievably hard working over this period. Yeah. The public health and the adult social care and all the council officers have done heroic work alongside partners in the NHS. So thank you for the work you've done. I'd also like to add to that, the thanks to committee services for the way they've picked up this technology and run with it and actually made us change the way we do things. So well done to the committee services as well. Thanks, guys. Good night.
Good night.
Bye.
So what are there?